All right. Hello.
Dana.
Welcome, Dr. Fankhauser. And I wanted to give everyone a second to join us. So I wanted to review this interview right now, of course, is live. It will be available on our Instagram in just a little while and on dwtnmedia.com, which is a project affiliated with Downtown Bentonville. Questions were submitted for this interview over the past few days. We will not be taking live questions or comments at this time. And our ultimate goal with this is to provide quality, factual information straight from a source that I trust. I think a lot of people in our community trust you. Full disclosure, Dr. Fankhauser is my doctor. But we want to share this information to the community, period. No sensationalism. We just wanted to share the facts. So welcome, Dr. Fankhauser. Thank you for joining us.
Thanks for having me.
All right, we want to talk just really quickly. I want to lay that foundation of who you are and where you gather your facts about COVID-19. So Dr. Fankhauser has a successful practice in Northwest Arkansas called Direct Care Clinic of Northwest Arkansas. You graduated from UT Southwestern Medical School. You completed a residency at UAMS, and you're board certified in both internal medicine and pediatrics.
That's correct, yes.
You also have a pretty popular Facebook following, and you have been posting a lot of information throughout this pandemic. A lot of it has had some legs on Facebook and really gone locally viral. So I want to ask you, where are you getting your information so that we know where you're getting it as we start to go through this interview?
Sure. So when I decide to post on a particular topic, it's usually because I've received questions from several of my own patients, right? Patients who ask things like, what do you feel about X, Y, or Z, right? Based on sort of regular news sources. When I decide to post, there are a couple of places where I get information. As I talk to other friends who are involved in academic medicine, who are involved in research. I talk to acquaintances basically through groups that review articles that have recently been published, and of course I'll go to the articles themselves, right? I try to use basically primary source data, means it's directly from the people rather than report from what the original researchers were saying. So part of being a good physician is learning to read research material, and learning how to interpret it, and learning how to figure out what questions should be asked as a result. So.
Sure. Now, we want to move on now that we know where you're getting your information. Of course, Arkansas now has a mask mandate in place. And for all of us that are on Facebook, it is kind of a wasteland right now of debate over the health ramifications, the politics. So I want to ask you, as a physician, Dr. Fankhauser, you have access to quality information. What do you advise your patients as far as mask wearing?
Sure. So there's good evidence for COVID specifically that countries, when they do adopt a mask mandate and people are routinely wearing those masks, that their rate of spread, and hence the rate of folks who die of COVID, actually decreases pretty dramatically. There's good data out in European countries, especially, who adopted mask mandates at various times, and looking at how they fared before the mask mandate and after the mask mandate, and comparing it to neighboring countries and such. It should be clear that I don't think any reasonable physician would say that masks alone are the answer. Right, that's part of the group of public health suggestions that include physical spacing and frequent hand washing. There's nobody who is saying we can wear a mask and not do any of those other things, and life will be back totally to normal. We have to do a combination of things for that to be effective.
In your medical opinion, and I'm going to ask you a really blunt question,
Sure.
is COVID-19 an overblown medical issue? Is it a political issue? What are the statistics showing you?
Yeah, it has been politicized, unfortunately. It is not overblown. If we could magically cure everybody with COVID right now, nobody else who was sick from it died, COVID would still end up being the 6th highest cause of death in 2020, more than likely. Historically, cancer and heart disease are first and second, and there's a number of illnesses that finish 3rd through 5th, and COVID is currently 6th with about a little more than 140,000 people who have died in the US so far from it. So it is not, we're not overblowing it. This is a serious illness.
Many of us, your patients, I'm sure, have texted you. I have a cough. You're laughing because do I have COVID-19? And there's a real slew of symptoms to keep an eye on. What are you advising your patients? What is that tipping point that you need to go get tested?
Sure. This is one of the reasons why this illness is so hard to control, because, you know, if you had strep throat, you would call me, your child had strep throat or whatever, you'd call me and say, hey, we have a fever and sore throat, and I could tell you, okay, this is likely strep throat, or hey, it's not likely to be strep throat based on what you told me, and then we could do a test and get the result back in a few minutes and be able to tell you, yeah, you have strep throat, or no, you don't have strep throat, and we can move on with our day. But COVID presents with such a strange variety of symptoms that it's not always real evident. So what I'm telling my patients is, if you have anything that resembles cough, sore throat, shortness of breath, unexplained fatigue, unexplained muscle aches, anything that sounds sort of like a viral illness to you, even if in 2019 you would have been like, oh, I'm fine, I'm going to go to work, I'll be okay. In 2020, you at least at a minimum have to decide, I'm going to separate myself from the folks who I might put at higher risk, right? And if you have any combination of that fever, cough, sore throat, shortness of breath, especially if you've had a potential exposure, I would advise testing earlier rather than later. Yeah.
What do we do when we kind of turn the corner towards fall and we run smack dab into flu season?
Yeah.
How are you prepared to tell the difference between, you know, flu symptoms and COVID symptoms? And are we all going to be locked down again because it's flu season and a pandemic?
So a lockdown is very much a political decision, right? And that's not something that public health officials should weigh in on. But there are other things that go into it on whether or not we should start to contract what we're allowed to do besides just COVID, right? We need folks to be able to feed their family and make money, right? And so that there's that decision is not simply is COVID a risk or not, because it will be for the foreseeable future. But that being said, going into the fall in the world of pediatrics, especially as kids congregate in schools, and they get all the other respiratory illnesses, right? In 2019, if you would have called me in October and said, little Jenny has a cough and sore throat, I would say, that's probably a virus. Have a great day. Keep her separated from her friends or at-risk family members until she's mostly feeling better. In 2020, that becomes a lot harder on families, because if you called me and said little Jenny has a cough and sore throat, I'd say, well, she needs to stay away from everybody, right? She needs to be as separated from everybody as we can make her, based on like reasonable separation based on age, right?
Right.
So it's clear what she has, or we've done a COVID test or whatever is the next step. So it's going to be challenging for schools and for pediatricians to know exactly when to make that call on when to close things, when to test people. That's not going to be an easy job for sure. But yeah, this fall is going to be a hard one, I think. So.
And we are going to do a separate interview on school-related topics, but I do want to loop in this question from Julie, and I'll show it below here. She wants to know if you have any suggestions beyond a multivitamin of what a child could take, and really adults as well, to boost their immune system, whether they're going to school or work or anything else.
Sure. So there have been several suggestions for vitamins that might work, but just as a preface, none of them have definitive studies that say take this and your risk for COVID is lower. There is a correlation between a low vitamin D level and the severity of COVID, but vitamin D has historically been associated with risk for a number of different seemingly unrelated illnesses. And every single time a researcher tries to pin like the vitamin D deficiency is the cause, we actually end up finding out that it's essentially just a marker for the overall general health of the person who had the vitamin D level measured, because vitamin D is increased by being outside, having sun exposure, which usually in America means you're doing some sort of physical activity. And it also tends to be lower in people who have chronic medical problems or chronic inflammatory conditions. So I would guess vitamin D for COVID is going to be the same thing. It's a basic marker for how healthy a person is in the first place. That being said, an age-appropriate dose of vitamin D is very safe, and you're not going to harm yourself with it. There are folks who suggest that zinc might be helpful. I've yet to see convincing evidence of that. Again, if you're taking an age-appropriate dose of zinc, you're not likely to do yourself any harm. The biggest side effect for zinc is essentially gastrointestinal issues.
Sure. Okay. I'm going to take that one down. I want to talk to you a little bit about something you posted, and I'm just going to describe it to the people that are watching. But imagine a bullseye or the Target logo for those of us that like to shop. You talk a lot about your circle and the people that you're exposing yourself to right now. Can you speak a little bit to those different kind of levels or the different parts of the circle and that theory of exposure?
Sure. So one of the things that has to happen with infectious diseases is you have to do something called contact tracing if you're going to try to control it, right? And what contact tracing is we determine the most likely period where a person is infectious, and we try to find out every single person that they were in contact with from the earliest that we would assume that they're infectious until the present day, right? And so what I would suggest to folks is obviously the bigger that list is, the more likely it is, firstly, that one of those people are going to be the person that infected you, or the more likely it is that you've spread an illness to someone you care about or love. And so what I try to advise my patients is not in an adversarial way, but you need to decide who your us is and who your them is. And your us are all the people that you want to have in your life and that you guys have agreed upon. These are the risks that we're willing to take to be in your life, right? So an example would be grandma, grandpa, etc. Once you've kind of decided who that us is, the high-risk people in the group should really be the ones that kind of help set the rules, right? If grandma says, I don't want you in my home if you've been around someone outside of our family in the previous 14 days, that should be grandma's prerogative, right? And you can have stricter rules than the high-risk person, but you really shouldn't have more lenient rules than expect the high-risk person to just accept them, right? So what I tell folks is, you've got your you in the center, right? And all the people that you're going to be around surround you, and then all the people that they're going to be around. And so if you don't have agreed upon rules on who you're going to be around, especially in high risk scenarios, then essentially everybody that anybody in your circle is around is now part of your circle, and that's not doing you many favors. So,
right.
Yeah, it's a way to kind of differentiate who gets more access to your personal space and hence who theoretically is putting you at a higher risk versus who doesn't.
Sure.
So.
With that, a lot of people are going back to work. Kids are about to start school. Some of them will be going back physically to school, as far as we know. What do you suggest as far as a mask? And I've heard, maybe this is an old wives' tale of if you put the mask up to your face, you shouldn't be able to blow out a candle. Now, I have a mask like that, and I can't breathe. So tell me, what should you be looking for a mask for your child, a mask for an adult as well?
Yeah. So odds are, if you can blow out a candle, that mask is not really particularly blocking much in the way of airflow. And so the point of a mask is to say, for example, I cough and stuff goes everywhere, right? But if I have a mask right here, I cough, and the majority of it hits the mask. Unless you have a high quality medical grade mask, it's not going to catch all of it. Nobody is saying it's going to catch all of it, but it's going to catch a good portion of it. And then if you have the mask and all the germs come this way, a good portion of them are going to hit the external surface of that mask, as opposed to just going straight into your face, right? So if both folks are wearing masks that are even average quality, that risk drops pretty significantly. As far as actual specific masks, Johns Hopkins actually has homemade masks for both adults and children designs that you can, if you Google Johns Hopkins mask, I'm sure you could find it pretty quickly. There is a link on one of my Facebook conversations of my last Thursdays. Basically, ask me anything question. I think someone asked about mask designs, and there's the link on there if you can't find it somewhere else. But a cotton blend mask appears to be pretty effective for slowing the spread of COVID. So.
Okay, and we can get those. I mean, you've seen them everywhere these days.
Yeah.
This is kind of a random follower question. Do you have any indication that COVID-19 is spread through air conditioning? We've seen a story about, it's spreading faster in the South because it's hot and humid here, and we crank up the air. Is there any indication that that's true?
That's actually not super clear right now, right? This is a big debate in the medical field of, it seems like the vast majority of COVID spread is through what are called droplets, which is like when you speak, little particles of spit come out, or when you breathe or eat, sing, cough, anything in which something is coming out of your mouth or nose, there are little droplets of saliva or spit or liquid that come out. Sorry, that's gross. That seems to be the majority of the way that COVID spread. And the reason I say that is because if COVID were totally an aerosolized illness, if that's how it spread in its entirety, then masks, like the surgical mask, the homemade mask, really probably shouldn't do much of anything.
Sure.
That being said, there are some scenarios in which COVID can be spread via aerosolized process, and mostly that's going to be in a healthcare setting when someone needs to be intubated or have a procedure done, especially in their upper airway. That puts the folks in the room at a much higher risk, which is why if you've known someone who's had surgery since March, they've had a pre-op COVID test to ensure that they're not going to aerosolize that virus in the room. But for the majority of people, even in a hospital setting that's not doing aerosolizing procedures, there's really good data out of Boston that requiring both a employee and a hospital visitor mask policy drop the hospital employee COVID positive rate to essentially the same thing as the community at large. So it more than halved it, which is pretty suggestive that mostly it's spread via droplets. But there is actually a fair amount of debate on exactly how much is spread in other fashions.
So let's talk about spread on countertops. When this all began, I was really good about wiping down my groceries, and then I stopped because it's really a strenuous process. Is that something that you still suggest?
I wouldn't do that. I don't think I did that ever from the beginning. You know, if you put your groceries up and then you wash your hands, you're going to end up accomplishing the same things with frequent hand washings without having to use as many like Lysol spray canisters or alcohol pads around the house. Definitely with the original SARS, the one that appeared in 2002, 2003-ish, there was, by the time that outbreak was done, there's pretty definitive evidence that frequent hand washing was an important part of slowing the transmission of it. So what I tell folks is you should wash your hands a whole lot more than you did in 2019. Soap and water is probably fine. Alcohol-based hand sanitizers are definitely effective, although there's been a fair number of sort of last-minute alcohol hand sanitizers that have been made that have not the right type of alcohol in them, and the FDA's had to recall a bunch of those. So if you're buying something from a alcohol hand sanitizer company that you're not familiar with, right, you should probably check the FDA list before you start allowing yourself with it.
Okay, so do a Google search and check your hand stuff.
FDA hand sanitizer recall. It's like dozens of companies now.
Mm-hmm. Yeah, I did see that as well. So should we all get tested if many of us could have COVID-19 and be asymptomatic? Is this a situation where until we're all tested, we just really don't know who has it?
Yeah, that's logistically in the U.S. would be virtually impossible to test everybody in a timely fashion. We don't have the supplies to do that right now. Countries that have successfully controlled this thus far and are more back to sort of their everyday regular life were effective at doing that essentially by doing really effective contact tracing, which is, again, say Mr. Smith gets infected. Mr. Smith then has the list of people that he had seen in the time frame in which he was infectious. Those people are contacted. Those people quarantine themselves. So even if he infected one of those people on that list, it's a transmission dead end because they're quarantined. Mm-hmm. That's also a challenging job in the United States. For decades, the United States has underfunded public health, and we don't have enough contact tracers to do that at this point in the United States. So universal testing, while it would theoretically be helpful if everyone agreed to quarantine or isolate afterwards, isn't really a logistically viable option right now. So until we've controlled the numbers of new cases enough, essentially, we're still going to have to do somewhat targeted testing just because of the nature of the availability of testing supplies at this point.
I'm going to pull over one of these questions, and I hope it's okay. Amanda here is just asking about rapid tests and if they're in place here in Northwest Arkansas. Do you know anything about when that would happen?
So there are theoretically some places that have rapid testing available. By and large, they've been reserved for inpatient settings. The hospitals do rapid tests if they have an emergent surgery or if there's someone that they need to admit to the hospital who they suspect has COVID, so they can decide if they need to be on the COVID unit or can they be potentially somewhere else. They're not readily available in Northwest Arkansas. They're basically not available in Benton County that I'm aware of in an outpatient setting at all right now. So no, while they're helpful, they're not, to the best of my knowledge, there's not anywhere in Benton County that as an outpatient you could go and get that done.
Okay, I want to ask you one more question. When is this going to end? What is the likely way it ends? Please, we want to know when this is going to end.
Yeah. Hey, there are a few possible ways this plays out. And these are listed sort of in the order that I would prefer. First, if a readily available, safe, and effective vaccine existed, and there are several that are that have pretty promising early data. If we could just prevent it altogether, that would obviously be the best option. The next best option is if we find a readily available, affordable oral medication that was actually genuinely effective at reducing severity of symptoms and decreasing infectivity. That would be great. And though there are several drugs that have been studied, none of them have clearly panned out as a good option for that. The next step would be essentially we have really good inpatient options for it, so that if you happen to do get really sick from it, we have good medications to make it less likely that you die or get very sick from it. Dexamethasone and remdesivir are both at least semi-promising early options, but not so great that I would say we're at that point where we could just say, hey, if you get sick enough, we can just give you these two things and you're going to be great. And then kind of the last two options are if we had developed what's called herd immunity. I don't know that that's a thing for COVID, right? There are debates about exactly how infectious COVID is, and the more infectious it is, the higher number of people you need to get infected. And most people are saying we're going to need something like 70% of the population to get infected, which would be a disaster. I mean, 70%, even if we use the low mortality numbers, means we would have hundreds of thousands more people die from it. That's not really a result anybody wants. And then like the worst case scenarios, we literally, none of those pan out. It becomes part of our life and we adapt to it. And I think that's probably the least likely out of the group. Again, we have already, this is an illness that we've known about for half a year, and already we have immunization prospects, and already we have inpatient medications that are effective. So I don't think this is just a thing that we just live with forever. I think we're going to have some other options. But those first several options, the vaccine and oral and IV medications, those take time. So it would be surprising to me if we have a genuinely good, widespread, available option in 2020. It would be shocking a little bit, and would be great, right? Like great if we're talking spring 2021. There's some of the vaccines that are in studies, if they continue to pan out, might become available as late as 2020. But that's a really big if, right? We usually talk about vaccine development over 5 to 10 years. So to make one in 10 months, it would be, incredible. It would be way outside the norm of what we've done in the past. So,
Dr. Fankhauser, you are going to continue to do Ask Me Anything on Facebook on, did you say Thursdays? Is that correct?
Yes, ma'am.
So if people want to follow you and follow along on the information that you're sharing with the community, that's a great place and a great source for updates and information. For those of you that ask questions, thank you very much. If your questions are school related, we're doing a separate live interview with Dr. Goss on Friday, and you can catch us on that and continue to submit questions today and part of tomorrow for that interview. Thank you, Dr. Fankhauser. Thanks for everyone that was watching and submitted questions, and thank you for answering every one of them. We really appreciate it.
Thanks for having me. It's good talking to you.
All right. Bye-bye.
Bye.